Good morning, Dr. Rice.
Morning, Natalie.
How are you doing today? It's the afternoon here in Connecticut.
I was going to say good morning, but it's
But good morning to you. It's good afternoon. So everyone, we are so happy you're here. Welcome, welcome. It's a beautiful day here in Connecticut. And my name is Nathalie Bonafé. Before I introduce my special guest today, let me say a few words about who I am. So I'm originally from France, that's full disclosure. I like to start with a little bit of humor. And I am located in New Haven, Connecticut, that I've called home for the past 22, 23 years. My background is in biochemistry, molecular biology and health. And I've spent about 25 years working with various research and development institutions. 4 years ago, I started a private practice as a holistic health care advocate and end-of-life coach, also known as doula. So I basically advocate for self-determination. So, but very, very quickly working with patients and families at end of life, I could see the direct correlation between menopause transition, and the way we age. I have therefore included a menopause transition in my advocacy into my practice. You will find some information about this on my website, www.nataliebonafé.com. So when I first met our guest, Dr. Sandra Rice, and I read her book she's going to tell you about, we very quickly connected, and we agreed that there was a major need for more education at menopause transition. This presentation will explain to you why this is so important. Dr. Rice, thank you so much for being with us today. It's a great honor to have you here. And it's wonderful that the technology is allowing us to be together while we are on the different sides of the country. So that is really a good thing. Thank you, Zoom. I'm going to read your bio, and we will follow with the presentation and the question and answers. So let me find your bio. Dr. Rice. Dr. Rice is board certified internal medicine specialist with 35 years of experience caring for women in menopause and beyond. Throughout her career, she has witnessed the pendulum swing back and forth regarding the advisability of hormone replacement and knows how difficult it is for women to find reliable information about the benefits and the risks of estrogen therapy. As a member of the North American Menopause Society and International Menopause Society, she has closely followed the studies and the research on menopause treatment and has been passionate about educating midlife women on how best to manage their health during this important phase of their lives. Did I miss anything, Doctor?
That's terrific. Thank you, Natalie.
So I'm going to let you start. I have a question. So, Dr. Rice, women have had menopause, forever. This is every woman gets through that stage when she leaves. But I noticed that we are in the 21st century, and in the 21st century, the first symptoms of perimenopause seem to all come as a surprise to most women. So why is that?
That's a great question. I think that a lot of women view menopause as something that's going to happen to them at some point in the future when they're old. And they don't realize that for a number of years before the actual menopause, there's some significant hormone changes going on that can really impact them physically and emotionally and mentally. And so when they're in their early 40s or even late 30s and they come into us and we say, you know, you're in perimenopause, you know, it's a shock because they just, I think, weren't expecting it and they don't know enough about it. So I thought that would be maybe a good place for us to start, is to try to help people understand better what perimenopause is, so they will be a little more informed, you know, for their own particular situation and health. So one way I like to look at this perimenopause phase is to actually look at the whole spectrum of a woman's reproductive life. And we have divided it into 3 basic stages. We have our, what we call our reproductive stage. We have then this transitional stage, which is perimenopause. And then we have our postmenopause stage. So let me go through each of those a little bit and what the symptoms and the hormonal changes are. So the reproductive stage starts after puberty. And at the time of puberty, we have millions of eggs literally in our ovaries, but they're all dormant. And one thing that is important for women to understand is that around each egg is a layer of cells, and they're called the follicular cells. And the follicular cells are what make our 2 female hormones, estrogen and progesterone. So at the time of puberty, the eggs are dormant, the follicular cells aren't very active, and so things, you know, we haven't become entering our reproductive phase. After puberty, then everything gears up. The eggs are released once a month, and that causes our monthly menstrual cycles. At the same time, the follicular cells have matured and they're making a lot of estrogen. So the reproductive phase is a time where we think our hormone levels are at their maximal levels. They cycle up and down every month a bit, but they're still at very high levels. Now let's just jump over that transition period into postmenopause. Menopause is actually a point in time. It's that point in time when your ovaries have no further eggs. So no further eggs and then no further hormones. So menopause is that point where the last egg goes, and then postmenopause is all those years after that. So those are characterized by hormone levels that are very, very low. So we have this phase where the levels are high, this phase where the levels are low, and then we have to get from point A to point B. That's perimenopause. Now, this doesn't happen overnight. The only time it would actually happen overnight is if a woman had to have her ovaries taken out by surgery. For most of us that don't have surgery, it's a gradual transition. And it takes a long time, actually. The average age of menopause in the United States now is 52. And we have a 5 to 7 to 8 to 9 to even 10-year interval where things wind down. And so the average age of perimenopause would be 47. But since menopause can happen between 45 and 55, perimenopause can actually happen in the late 30s, which again, I think a lot of women in their late 30s aren't expecting that. So the other thing that's important to realize is that the transition doesn't suddenly doesn't go down in a linear fashion. It kind of goes, the hormone levels will go down and then they'll up and down and up and come up and down. And it's this very erratic and unexpected hormonal fluctuations that really, are the upsetting part, because you never know what to expect. You never know, one day your hormones are going to be good and then the next day they're low. So this, and this fluctuating level is also responsible for a lot of the symptoms. So let's talk a little bit about the symptoms. The hallmark of perimenopause is menstrual abnormalities. And what happens is the egg no longer is released every month. The first thing that happens is that an egg frequently is just released too soon. So if the egg comes out too soon, that shortens the cycle. So a lot of women will first notice that their cycles are getting shorter together. Instead of 28 days or what they're used to, they go to 26 or 24 or 21, they get closer and closer. And the next thing that happens with the eggs is that they're not released at all. And so what happens, you don't have a period. You go 45, 60, or even more days without a period. So it's this kind of never know when your period's coming sort of issue that happens with perimenopause. But I think more profoundly affecting them is what their hormones are doing. And as I mentioned, the hormones can go down and up. And one part of our body that doesn't like this up and down business is the brain. Hormones have a huge impact on the brain. A lot of women don't realize that. They're extremely important, or estrogen for sure, is extremely important in temperature regulation and appetite regulation and energy balance. Estrogen is important for mood. It's important for thinking and cognition. So when your hormones are doing crazy stuff, your brain is severely impacted. So one of the cardinal symptoms is the thermostat problem, and that's what causes these hot flashes that are so characteristic not only of menopause but perimenopause. So women can certainly get hot flashes years before they go into menopause, and the hot flashes can be variable. I mean, they can be there for a few months, and then the hormone levels get better, and then they go away, and then they come back. And again, totally unpredictable.
Yeah, and they can happen at home or at work.
Yeah,
anytime.
Yeah, and various things trigger them, emotional things, caffeine, alcohol, temperature changes. And then the equivalent of the hot flash is the night sweat. And, waking up, throwing off the covers, it sounds funny, but when you're in the midst of it, it's not very funny.
It is not funny.
This business at night, it clearly interferes with your sleep. And actually, that's another cardinal symptom of perimenopause is sleep disturbance. Women who never had problems with their sleep suddenly find trouble falling asleep, trouble waking up in the middle of the night. And it appears actually not completely, even totally, because of the night sweats. It's another feature of the hormonal changes in the brain.
And it leads to exhaustion. I mean, it's feedback.
I mean, poor sleep disturbance is associated with not only your functioning, but your health. There's lots of health problems that like diabetes and heart disease that correlate with poor sleep. The other symptoms that are very common as far as the brain goes are mood issues. The estrogen plays a lot of important roles in regulating the chemicals in our brain that stabilize our mood. We've probably all heard of serotonin, which is important for mood stabilization. When that process is disrupted, women suddenly they have feelings and emotions that they're not used to. They can be more anxious, they can be more depressed, more irritable. And women who especially have had past history of those, like women who have had postpartum depression, PTSD, even childhood adversity. We were talking about that, Natalie, earlier.
Yes.
Those women that have had those problems, it comes out in a more pronounced way sometimes during the perimenopause. And then the final brain issue is just our cognitive abilities. Estrogen plays a big role in some of the other chemicals that deal with that. And so women start, a little more memory issues, the concentration isn't so good. And these sort of things are, clearly affect a woman's functioning, in their day-to-day life and their work. So, I mean, when you think that goes on for quite a while, that's just a pretty big impact on a woman's life. So that's the perimenopause. Now, finally, when the hormone levels finally do get down, and actually we'll talk about right before postmenopause, some other symptoms that occur when the estrogen level finally gets really low are areas where estrogen plays a big role as far as tissue health, and one of the areas is down in the vaginal and bladder area. So as the estrogen is very important for keeping those tissues, the cells, healthy, and the lining of the tissues down there moist and thick. And so as estrogen level goes down, women will experience thinning, dryness, itching, burning,
Pain,
and also sexual dysfunction. So again, another big thing that happens to women that impacts their day-to-day life. And then postmenopause, again, where we are with that is low estrogen levels. So all those things that are impacted by estrogen are going to continue to be a problem. Hot flashes tend to persist. The vaginal changes definitely persist and get worse. The mood, at some point, a lot of the mood issues do get a little better, and depression tends to get a little bit better. But cognition, for some people, never quite gets back to where it was. So postmenopause is that long period without estrogens that we're going to talk about in a little bit more.
Did you want to say something about the skin, for instance, like the skin or the joints? Was there something that you noticed there, or?
Yeah, so I was going to talk about that a little bit about, for postmenopause, what are the health impacts now in the postmenopause? So we can kind of jump into that. So this is something that I'm very passionate about like, is it a good idea to go a long time without estrogen? We know that the average age of menopause is 52, plus or minus 5 years, but the life expectancy of women is 82.
It has changed so much since the 20th century. I mean, it's a new, when we think about it, it's fairly new. We didn't used to live past 50 for a long time, right?
The average life expectancy in the year 1900 was 52. So
absolutely.
So
menopause is a new thing, actually. It's from the 19th century.
I agree. And I think that's what a lot of people are suddenly kind of realizing, is that we don't know a whole lot about that because we don't have that much history, as far as, to study what's
yes. So now would it be, should we see menopause as maybe, could we think about preventing the damage, because we never had to have that question before. We didn't know, but now we have a couple of generations that have gone through that, or 2 or 3, I would say.
Exactly. Yeah, let's talk a little bit about, let's talk a little bit more about what estrogen does in the body. And that's part of the reason that I really was motivated to write my book, is because I think if women understood better what estrogen does in their body, they would have a better sense about whether or not it's something they might continue after menopause. And so I think women tend to think of estrogen as, well, let's see, it's important for making our female characteristics, our breasts and our, that sort of stuff. And it's important for making our ovaries and keeping, doing the eggs, and it's important for the menstrual cycles, and it's of course important for pregnancy. So we kind of think of estrogen and progesterone, both of our female hormones, is kind of, that's their big job. And gosh, when we're 52, we don't need any of that stuff anymore. So, but the truth of the matter is that estrogen plays an important role in just about every part of our body. I mean, it's like oxygen. Our body needs estrogen throughout our lives. So let's talk a little bit. I'd like to talk a little bit about, explain that in a little more detail. So the first area where estrogen is critical is our bones. And this, I mean, I think we tend to kind of think, okay, well, you get older, you might break a bone, but breaking a bone is a life-changing event when you're older. 50% of people, after they have a hip fracture, will either die or end up completely dependent in a nursing home. I mean, it's a very huge health issue for all of us.
Absolutely, I see it all the time.
So estrogen, so our bones are always, I love the science of this. That's why you have to bear with me on this.
I like it too.
The bones are always in what we call remodeling. Inside of our bones, there's little cells that are constantly tearing away a little bone and then replacing it with new bone. So we always have new healthy bone. It's just this process. It's called remodeling, and this keeps our bones, healthy and strong throughout our lives. And throughout our reproductive years, the balance is in balance. So, what gets destroyed gets replaced. So, the bones are always, keeping themselves in the same basic, configuration. What happens, what estrogen is doing is estrogen is keeping the lid on the little Pac-Man cells that destroy the bone. So estrogen keeps those guys in check. Now, when we lose our estrogen, they go crazy. And literally the bone is broken down faster than the bone building up. So basically we have a net loss of the, the strength of the internal structure of the bones. And this is a pretty dramatic process that actually starts a couple years before menopause. And this is kind of, we're just kind of really grasping that this is an issue.
So how much can we lose in 2 or 3 years?
So the average loss is 10%, 10 to 12% in 5 years. And some women, because of genetic issues and other issues, can lose up to 25% of their bone in 5 years. And let me just explain what a 10% loss can mean to you. And this is, I think, really interesting. I think a lot of women are familiar with what we call a bone density test. You go in and they check and see what your bone density is, and you get this number, like a normal is 0 to 1. And if your number is like minus 1.5 or minus 2 or minus 2.5, that means your bones are getting thinner and thinner. So osteoporosis is if it's minus 2.5. A 10% bone loss can drop you a whole point. So if you get your bone density at 0, yeah, I know, it's amazing, 0.5, 5 years from then, it can go down to a minus 1.5 without any intervention. So anyway, it's getting a little off the subject, but I just think that's impressive.
Well, this is important. This is important.
The bones. That's one of my big things is my background is in internal medicine, and unlike gynecologists who focus a lot on women during their reproductive years and their pregnancy years, internists as myself, our specialty is adult and geriatric patients. So we see a lot of the problems that happen to women as they get older. But osteoporosis and bones are a big issue. So does estrogen therapy prevent that bone loss? Yes. There's no question about it that women who take estrogen, their bone loss will not, have that accelerated loss during this transitional and early postmenopausal phase. The other area where where estrogen plays a huge role is our heart. Women have lower risks of heart attacks and heart disease than men throughout our lives until menopause. When we hit menopause, the risk of a heart attack and other heart complications accelerates rapidly, and we become the incidence in women is as frequent as in men. And one of the reasons that we're protected from heart attacks and heart disease before menopause is because of our estrogen. And we know many areas where the estrogen does do beneficial things to prevent heart disease. Number one, it lowers our bad cholesterol and raises our good cholesterol. Estrogen actually is anti-inflammatory and antioxidant has those effects on the lining of the arteries. And something that's a little more technical, but it's a huge factor in cardiology circles, is that estrogen raises this chemical called nitric oxide. And nitric oxide is something that's released in the arteries to keep them open and keep them healthy. So when we lose our estrogen, all these factors start all of a sudden building up, and women start getting little plaque deposits on their arteries. And the plaque is that's got cholesterol and other junk in it that starts building up, and then eventually it builds up to the point where it can block an artery. If it blocks an artery in the heart, it causes a heart attack. If it blocks an artery in the brain, it causes a stroke. So the risk of this hardening of the artery and these heart disease issues accelerates after menopause. And estrogen therapy can reverse a lot of those changes, before they happen. Once you get plaque, you can't get rid of it unless you go in and have a bypass, or they go in and try to do a little Pac-Man sort of maneuver that, again, you'd rather prevent it than having to deal, with it.
Yeah, then it's too late.
Yeah, this is getting to your question, Abby, about what to do about prevention. So the bones, estrogen is extremely important for the bones. It's extremely important for the heart. Here's another area where estrogen plays a huge role that a lot of people don't appreciate. So when we're girls, when we don't have our hormones, we have this kind of linear figure. And then when we go through puberty, we start making hormones. And one of the things that estrogen does is it puts fat in the female areas. So it puts fat, in the breasts, on the hips, on the butt, so, and it specifically tries to keep the fat from the middle. So that's why women end up, with this, this shape, right? This hourglass shape, as part of the fat deposition. And that's because estrogen actually, is kind of directing where the fat goes. When we lose our estrogen, even in perimenopause, when the estrogen level starts going down, the fat gets redirected to the middle. So we start getting what we call central or abdominal fat. And this is not just a cosmetic thing. This is just not, extra love handles that we don't want. Abdominal fat is actually also inside the internal part of our abdomen, around what we call the viscera. The viscera are our internal organs. So this internal fat is actually bad. Regular fat, that we have on our butt and places, is kind of just stores energy. It's not doesn't do a whole lot of other stuff in the body. But this internal central fat actually puts out chemicals and hormones that do other things that like affect our energy. They go up to our brain and talk to our brain about whether or not we're full or not, and they cause inflammatory chemicals, and it affects the way we handle blood sugar and insulin. So
diabetes.
Exactly. So people who have this central fat are much higher risk for diabetes. Estrogen prevents this central fat, and estrogen in studies, even some very major studies, which we'll talk about, prevents diabetes. So again, here's another chronic health problem that we in my field deal with is diabetes and all of its complications. If we could prevent it, again, that's where I think our focus should be. And then the brain, we've already talked about estrogen effects on the brain. There's lots of stuff. There's some controversy about whether or not estrogen treatment will actually prevent some of the long-term damage that happens in the brain. But there's many researchers who are working on this, and a lot of evidence that's showing that estrogen, because of its anti-inflammatory effects, and because of its good on the blood vessels, and because it helps the neurotransmitters and even the synapses, that there's a lot of suspicion that estrogen will help prevent dementia. Again, if we haven't.
There is a lot of studies being done on that, and it's very striking.
It is
striking. Yes. 2 out of 3 patients with dementia, Alzheimer in particular, are women.
Yeah. Oh, yes. And that's
there is a link.
Yeah. I mean, this one study called the KEEPS study, that's the name of it. They're doing some very interesting research where they're actually looking at we can now do these, they're called PET scans. They're kind of like super duper MRI CAT scan things that look for specifically those little amyloid deposits. Amyloid deposits is the junk that we think causes Alzheimer's. You get these deposits in the brain, so they kind of kill off the brain cells. We can actually do scans that can find it, and they've done studies in this KEEP study where they're looking at the deposits on women who are on estrogen hormone replacement therapy and not, and they're finding less of those deposits in the women on treatment. So I mean, to me, the studies are looking pretty promising.
And it's just the beginning. Hopefully there will be funding for them.
Yes, that's exactly it. So those are some of the things that, estrogen does. And in my book, that was the way I organized the book, was try to look at each organ system and say, okay, what does estrogen do for the heart? What does estrogen do for the brain? And then I talk about estrogen and the skin, which is what started our little discussion here, is that estrogen is extremely important for keeping your collagen healthy. Collagen is this kind of protein network it's under our skin, It's also in our joints, in our discs. And without estrogen, I mean, it's clearly been shown that women do have actually more issues with hydration of their joints and hydration of their skin, wound healing, and various things like that. So estrogen is very important for collagen. Estrogen, there's some roles in the brain, in the eyes, in the ears, in the liver, in the gut. So lots of areas where estrogen plays a role. And again, just to emphasize to women that, estrogen is an important hormone in our body.
Absolutely. So
should we use that prevention?
With all of this, I mean, why don't we use HRT, for prevention then?
Thank you. That's this is the other part of the other answer. The other subtitle of my book is "Know Before You Say No to HRT." Women need to know the answer to that question. So right now, the guidelines, if you look at the FDA insert, which would come with an FDA prescription, or if your doctor kind of looks in the guideline book, it says you're only supposed to prescribe hormone treatment, which is basically estrogen, to treat bothersome hot flashes. And it's not approved to prevent any of these things. It's not approved. Let me just I'll qualify that and say it is actually approved technically to prevent osteoporosis, but only under certain situations, and that's when your bones are practically on the verge of getting a fracture. They're not approved to give to a healthy woman who just wants to prevent her bones from getting in the first place. So they're not approved for the heart, to protect the heart. They're not approved to protect the brain. They're not approved to prevent diabetes. You're only supposed to prescribe them for hot flashes. And so that's kind of what the doctors are having to kind of go by. So if you go to your physician and you say, no, if you're not having hot flashes, you try to live with them, we're not going to prescribe hormones. So let me tell you why we are in this dilemma right now. I started my practice back in, I hate to admit it, but I started back in the 80s. I went to medical school in the 70s. And back then, that was the standard of care. We encouraged women to take hormones. We, not just for their, not just for the fact that it would help them function, for their hot flashes and their sleeping and their vaginal issues. We told women that, this could protect, this will protect a heart attack. This will protect a fracture. And this will protect dementia. It will do so many good things for you. So you probably have noticed I haven't mentioned breast cancer yet. We would say, yeah, the studies are showing it may slightly increase breast cancer. I mean, women are so frightened of breast cancer, but really all the studies are not showing this huge increase, maybe a slight increase. So back then we would say, but all these other benefits, not getting diabetes, not getting heart disease, so much, the benefits are so much better than this relatively small risk. I don't want to minimize it because I know, cancer is a scary thing, but when you look at the big picture, we did really have we had good studies back then. We had some very large, good studies. So in fact, it was at the point in the 1990s that we wanted to say, all women should be on hormones. We should talk every woman into this, because if we can prevent heart disease, heart disease kills more women than all cancers combined. If we could do something to prevent heart disease. So let's get a study that really clarifies this once and for all. Because the other studies, they were great studies, they were good studies, but they were what we call observational studies, meaning that they just looked at thousands and thousands of women and looked at which women took hormones and which women didn't, and then compiled, the benefits and risks. They weren't considered what we call the gold standard, where you put one group of women on treatment and one group of women on a sugar pill, and you match the women for women, make sure they're the same weight, the same height, whether they smoke, so you've got two completely, similar groups of women, and then you see, what the outcome was. So in 1991, the National Institutes of Health launched this, multi-million-dollar study called the WHI. It's called the Women's Health Initiative study. And the idea was to once and for all, solidify, the heart benefits of taking hormones. And so it was a study that there was like 16,000 women. They were put into two groups. Well, two groups of hormone treatment, and I'll talk about that in just a bit. One group took both hormones, which is estrogen and a progesterone-like drug, and the other women just took estrogen. And then they followed these women for, it was supposed to be about 7 years, but it turned out to be 5 years. The first study that I said only turned out to be 5 years was stopped early because of two things. One is that there were, some women did get breast cancer, and they kind of decided ahead of time, well, if we got this many breast cancers, we'll just stop the study because, we just want to, we don't want to push anything or, cause any issues with, more women getting breast cancer than should not. So they stopped the study at 5 years, but they also found that at that point, there was actually more heart attacks in the treatment group. And so this was kind of like, oh my gosh, we've got, we have this amount of breast cancers, but we also are seeing this amount of heart attacks. So we're stopping this study. And just let me backtrack and say that we're not talking huge numbers. We're talking, maybe 1 out of 1,000 more women would have one of these things. So we're not talking huge numbers. But at any rate, statistically speaking, they stopped the study. But what happened was that the media caught a hold of this and said, study was stopped prematurely because of cancer, and that hormones cause heart attacks and hormones are bad. I mean, it was just kind of a very strange how the whole thing just got blown out of proportion, really, in a lot of.
And it was worldwide.
Oh yes, yeah, well, yeah, it was worldwide.
And the impact was not, it was global. It was not just in the US, because at the time my mother, was in France, I know people in the UK, Australia, I mean, you name it.
Yeah, so it was a big deal. I mean, it was, I mean, and of course, as physicians, we're like, oh my gosh, what is going on here? That all the other studies, said that hormones were good for the heart and good, prevented strokes and prevented.
It was erased. Basically, it was like eliminated from the books
because it was, this was a gold study. So that study led to the guidelines we have today, which is now 18 years later, that you shouldn't take hormones for preventive therapy. You can take them for hot flashes. But again, women and doctors were hearing, well, gosh, women should just put up with their hot flashes. Don't even treat women for hot flashes. This is crazy. So this, of course, was very upsetting to me and a lot of my colleagues who had treated thousands of women with hormones, and I mean, we didn't see obviously any of that on any kind of scale. And so there, and
major liability.
Yeah. I mean, and so, I mean, I think it was very puzzling at first. And that's one of the reasons I think I got so interested in the subject, is that this just doesn't make sense. And so I followed things very closely, as did many specialists in menopause. And it took a long time, but we finally kind of figured out what went wrong. But it's almost like it was too late by the time we really have figured out what went wrong with the study. So it's really important that people understand the issues with the study. So let's talk a little bit about the specifics of it. They recruited women because they wanted to, see if hormones would help the heart. Now, 50-year-old women don't generally have much in the way of heart problems, right? So they ended up actually recruiting older women. So the average age of the woman was 63. Some of them
62.
Some of them were older than 70. Very few, only a small percentage were around age 50 to 55. We would normally take estrogens. I mean, that's when you'd normally put women on estrogens, right? When they're going through menopause. So what they were doing was they took a huge number of women who had not seen or been on, their bodies had not made hormones, and they had not taken hormones for years, 10, 15, some even 20, a long, long time beyond menopause. And it didn't click at first, but in the last 10 years, there's been a number of studies that have brought to the foreground that putting older women who have not been on hormones for a long time and then throwing them back into their bodies, they're not going to act the same way as they did before. The body isn't going to recognize them. They're kind of acting like a foreign substance. And in some cases, they might actually cause some detrimental things. So I think that's the number one thing women have to realize is that the results of the study were really should only be applied to that kind of particular situation. The second part of the study was that the hormones that they used are not the same ones that we recommend today. But that was the hormones we had back then. I mean,
And they were synthetic hormones.
Well, it depends on what you define synthetic. Now, Premarin.
Premarin. Was it Premarin? Yes. Okay.
You know where that comes from? Pregnant.
Yes, from the horse.
Pregnant mare's urine, Premarin. So it's kind of natural, but just for horses, right? It's not really natural for people. But you're right. Premarin? 50% of what's in Premarin is a female hormone that's normal for us. It's called estrogen. But 50% are hormones that are normal for horses. So that was one thing that we were giving women. But the other thing that you were saying, Natalie, is the synthetic progesterone-like drug. Progesterone,
because it was also associated with it. Yes.
Yes, yeah, it was a synthetic drug because back then we didn't have natural, normal, what the body makes progesterone. So it was a pretty potent synthetic progesterone. So progestogen, progesterone is what your body makes, but a progestogen is a synthetic one, basically. So at any rate, what we now know, again, the research since the WHI is coming out, it's those synthetic progestogen type drugs that actually may be the most detrimental as far as causing the problems, as far as causing the heart issues and even the breast cancer issues. So what the problem is that the WHI was a study of older women on these drugs, but the guidelines just basically kind of ignored those little minor details and said all hormones, no matter what type, and for all women, no matter what their age, shouldn't be taking hormones for preventive therapy. Nobody quite understands, that distinction. And when you go back now, it makes sense why the older studies, and actually there's even been at least a dozen newer, pretty big observational studies, especially in Europe, that have again shown that women who take hormones at the time of menopause, right when they're transitioning, have less heart disease, less diabetes, less strokes, less dementia, and they actually even live longer. I mean, your life expectancy is longer for women who have taken hormones, at the time of menopause. And even interestingly, the WHI study, it was published in 2002 or 2003. It took quite a few years after where they actually teased out and looked, at the subset of women who were less than age 59, and they didn't have any increase of, any of those issues. They didn't have it. So it was clearly the older women that were the ones that were getting in trouble. And then let me just, say one more thing about the WHI study, as far as one of the details that people don't realize is that, remember I mentioned that there was one group that took the estrogen and a progesterone-like drug, and then the other, the estrogen. The reason they separated those two out is because if you have a uterus, taking estrogen alone causes problems. It can cause abnormal bleeding. It can could increase cancer of the uterus. If you take progesterone or a progesterone-like drug, that totally negates any kind of uterine problems. But if women had a hysterectomy, they didn't have to take that. So the second arm of the study, which they stopped the first one at 5 years. The second one, they kept it going for the full 7 years. So that came out a couple years later than the original WHI bombshell news. Interestingly, and they were older women as well, decreased risk of heart disease and decreased risk of breast cancer. So that was kind of our first clue that the progesterone.
And no one picked on it, like the first time around.
So it takes so long for medicine to, it seems like it's a bolt, to kind of push it uphill to make some changes. But anyway, so we're still have these guidelines, which are unfortunately sending the message that hormones aren't good, despite the fact that the North American Menopause Society, which is
I was going to get there. Yes.
society comprising of several thousand menopause specialists, they've all in their position statement endorsed that taking hormones at the time of menopause causes more benefits than risks. The breast cancer is still, a little bit of a specter out there. But again, if you look,
we have great prevention. We have really, really good tools for women at preventing breast cancer, at least monitoring the risks.
Yeah, I mean that's what the thing is for some reason this risk of breast cancer, even though it's 1 in 1,000 women on hormones might increase their risk, and that's we're talking both hormones actually at progesterone.
So, Dr. Rice, you obviously believe in the benefits of hormone therapy, like many, all of your colleagues at the American Menopause Society. Maybe younger, physicians who are freshly trained with the newer guidelines. I understand they may not have emphasized that, but I've checked the North American Menopausal Society. You're not the only one.
No.
That. You are not the only one. You are just many. So you do encourage women to take it. And so why? Can you tell us?
In looking at all the studies and making my own assessment as far as the benefits and risks, I just feel that the vast majority of women do benefit more than they would as far as a risk go. It just really comes down to that. I just am concerned about women's long-term health, and I feel that they just need to understand that the benefits are better than the risks. That's kind of my bottom line on that.
So you talked a little bit about the women with breast cancer. That is a little bit of a dicey subject. There are a few dicey subjects because we are all very different. There are the women who suffer from endometriosis. We have some questions for that. We have the women with a high risk of breast and ovarian cancer. This is of course to be monitored closely by you and your colleagues, at the individual level.
Yeah, I think that's the key, is that individualization of hormone therapy is key, because clearly, and even in the North American Menopause statement, their bottom line basically is that it should, whereas the current guidelines are saying treat only hot flashes if nothing else works, and only for the shortest dose at the lowest dose for the shortest period of time. That's not going to do really anything for prevention, but it may kind of get you through the hot flashes. But the North American Menopause Society basically is saying treatment should be based on a woman's goals and preferences. What's important to her. Is she worried about her bones? Is she worried about her heart? Does she feel that her breast cancer?
What are her goals? How does she want to be, empowered? That she needs to know. And even if she takes hormones, she should be told, explain how to check, the signs for potential, problems in the breast or in other organs that could be affected. So how about surgical menopause?
I think that's something that we're all learning about.
Because it comes suddenly. There is no 10 years of suffering, and it's usually younger women.
Yes, it's obviously so with surgical menopause, you're just suddenly stopping your estrogen progesterone, and that's extremely hard on the body. The other thing that, especially if you're younger, well, I guess where I was going with this is that you also lose your testosterone, which it's important for all of us, but the younger women, I think, are a little more.
And the tolerance for pain and, the consequences on pretty much everything.
Yeah, I mean, the symptoms from surgical menopause are much more intense, terrible hot flashes, night sweats, mood issues. I mean, there's many, many studies that show, their cognitive decline is just so dramatic, and that most, there's just a lot of studies that are showing, they're going back and looking at women who had their ovaries removed who didn't take estrogen replacement, just their heart disease risk, their diabetes risk. I mean, all those health conditions we talked about hugely accelerated if women have their ovaries taken out before they should. And
yeah, well, what I'm finding too is that there is very little education with it. It's like, okay, you're going through surgery with no booklet, saying, this is what's going to happen to you. So they think they're going crazy.
Yeah. Well, I think for many years, and I was probably guilty before I knew as much as I know now, that you just take them out. Yeah, your hot flashes, or you probably have hot flashes, but you'll deal with those. We didn't realize maybe the magnitude of other health risks with it, and so often it was kind of this general sort of like training that, well, if you're getting kind of close to menopause, go ahead and might as well. You're getting kind of close to menopause, and you have to have your uterus taken out. So a uterus is just, a hysterectomy is just removing the uterus, and the most common reason for surgery down there is like fibroids and abnormal bleeding.
And it's always tricky.
Yeah, you really need to take out the uterus, but a lot of times it would be like, well, you're getting close to menopause, you might as well take the ovaries along with the uterus, as long as we're in there. I mean, 1 out of 3 women have a hysterectomy, and a lot of those women, they took out their ovaries if they were getting close to menopause, and now we know that's not such a good idea. Don't take them out if you don't need them. And one of the statistics you and I were talking about is that 30% of women who have their ovaries and tubes removed are for unnecessary reasons, and that's a lot. That women, like you say, aren't really informed about. Okay, they say, well, let's take your ovaries out. That way, you don't have to worry about ovarian cancer in the future. Well, your risk of dying from ovarian cancer.
But at the same time, at least give them the option.
Yeah, at least explain to them. So, yeah, no, I think we're coming a long way, but slowly.
So remind me, I could never remember the name. So there is a hysterectomy where it's normally, just the uterus, and the combination uterus and ovaries. How is it called? I will never be able to pronounce it.
So the uterus is the hysterectomy. The tubes are a salpingectomy, and the ovaries are oophorectomy. So if you have a bilateral, that's bilateral salpingo-oophorectomy, hysterectomy, that's taking everything out.
Bon appetit. Yes, well, we're laughing about it, but it's just complex. So.
And so just as a final comment on the surgical menopause is that all experts, pretty much, I don't think the American College of Obstetricians and Gynecologists, the NAMS, all the major societies do encourage women to take hormone therapy after surgical menopause, at least until the time of natural menopause, which would be anywhere from average age of 52, but could be up to 55. And then after that point forward, the woman should be just like anybody else and trying to make the decision, well, do I want to keep taking hormones for a little longer, or do I stop? But at least they should take them up until the age of when they would normally go through natural menopause. And that's pretty dogma right now.
It's very, I just got, I will share with you, and I will share when we have the questions. I just got a new book about surgical menopause from the UK. a series of stories written by one of the women who host the menopause cafes in Scotland. So I will definitely share toward the end. It's a good resource, and I just received it yesterday. It just came out, so I will share. So that's really. So how about women past menopause?
As far as hormone therapy goes, yeah,
Tell us. It's always a big question.
that's a good point. I mean, that's a good point to emphasize. I mean, obviously you can tell I'm kind of a cheerleader for hormones, but what the issue, one thing I think have learned from the WHI is that you don't want to go years and years beyond menopause before you decide to take hormones. We just don't know enough about it, but you know, the WHI was a good study. It was just inappropriately, applied. And so we have to be concerned that a woman who is, it's kind of arbitrary, but people are saying 10 years beyond menopause or 10 years beyond when your body last saw hormones, maybe the window that you should not go beyond, so if you've gone more than 10 years, then maybe it's not a good idea to go on hormones. But that's mainly because there's the presumption that at that point you've already developed some hardening of the arteries or maybe some changes in your brain that maybe estrogen and progesterone, which is really the bad actor here, that could aggravate a problem.
So, Dr. Rice, I'm very sorry. I said I asked a question. I went ahead of myself on our outline, and actually, this was part of a question I should have asked about. With all the confusion, okay, between the WHI, what doctors recommend, what they can recommend, what they know they can recommend based on if they've done the research. And we really like the doctors associated with the North American Menopause Society when it comes to menopause. This is really important, I think. But with all the confusion, can you tell us briefly, can you please get us started? When should women consult with their doctors? Even if we've had among the participants here, some of us have had menopause, some of us have had hysterectomies, some of us have this, but we need to continue to educate women around us and to help one another. This is also part of the healing. So also, when should women consult their doctors? When should they consider starting HRT? What should they take? And we've had questions about estrogen and estradiol and all of this, and how long should they take them? So if you could, get us a little bit of an outline, because we enjoy so much each other, we could talk forever. If you could get this, that I think that would be very, very helpful before we take the questions.
So yeah, I mean, I'm kind of old school. I always believe people should have an annual visit with their doctor. The doctor gets to know them, know what, their medical situation is, where their values are, what's important to them. And then, age appropriate discussion on, where they are in their, their reproductive life. Are they perimenopausal, and talk about those symptoms and discuss what their, options are if they're postmenopausal and what kind of screening tests they should have. So I don't think women should wait and then finally start having hot flashes and go in. I think they, should go in and start talking with them. I'm 49 and I might be having hot flashes, just to talk about, those symptoms and what to expect and, start thinking about their future options. And then as far as when to start hormones, I mean, that's a good question. I think, again, because of the WHI, a lot of doctors kind of say, well, yeah, you're starting menopause or you're premenopausal. I mean, you're late perimenopausal, and try to put up with your hot flashes if you can, or maybe try over-the-counter stuff or some supplements and da-da-da-da. So, but I think you really need to individually sit down with a woman now, right? If a woman's having terrible hot flashes, if they're interfering with their life, then I think most doctors are pretty comfortable saying, at least the doctors who believe in hormones, saying, well, let's get you started on these. Certainly if you're perimenopausal, there's some different issues going on. I mean, if you need contraception, then that's a whole different thing. You don't just start on hormones if you need contraception, because you can still get pregnant right up until you release that last egg. So women who are perimenopausal that are having period problems that need to be regulated, they're probably looking at maybe some low dose birth control pills, or perhaps some estrogen with an IUD, or some other kind of birth control. So the need for contraception will play into a role as far as treatment.
There are so many options nowadays.
Exactly. As other perimenopausal issues that need to be addressed, as far as the mood changes and hot flashes, to talk, the cognitive behavioral therapy, there's antidepressants. So there's just a whole bunch of other hormone and non-hormone treatments depending on what the woman's symptoms are. So they have to be totally individualized. I'm kind of the school, though, as you get into late perimenopause and early perimenopause, I'm not of the school where just kind of wait and see. Why don't you wait and see, if you really need to take hormones? I mean, a lot of women are getting that response from their physicians. But really, when you think about it, there's a lot of reasons to take them sooner rather than later. First of all, just for your quality of life. I mean, why put up and be miserable for a year or two or whatever with sleep problems and hot flashes?
We need to be able to function in this society. I mean, it's the kids. For women who have children, the kids can be still young. The parents are aging. The workload, the need for income to put bread on the table. I mean, we need to be able to function.
Totally. I mean, that whole segment of just your quality of life and your ability to function. And then there's, the health issues that we've brought up is the bone loss that occurs early. That begins rapidly, as I mentioned, even before the last final menstrual period. And there's just so much research now coming about as far as the heart issues, is that even in the perimenopause, we're starting to see cholesterol levels, start the LDL, the bad cholesterol, go up. We're starting to see some early, women developing early plaque at that point in time. And so it's possible that even in late perimenopause and very early menopause, we're already setting the scene to develop some early, conditions on the arteries that could go on to a heart attack. So, if the research continues to show the benefits of estrogen, I think we will see much more of a push, not only for improving your quality of life, but for improving your future health by considering more aggressive hormone replacement. But again, that's a lot of my opinion. As far as
and we have the technology now. I mean, we have the technology. We have ways to track, breast cancer in a fairly non-invasive ways. We have all sorts. I mean, the PET scan, when it comes to brain, is a little bit hard to come along, but there are studies that enroll women that are at risk. A lot of them are free because it's part of those, scientific studies. So yes, there are a lot of options.
Yeah, and I guess that's all of us in our lifetimes wish that research and things would happen faster. I mean, things are happening fast, but not fast enough to make huge changes in what we recommend to patients. So again,
and it's important to talk to one another too, because not two women are going to have neither the same symptoms or the same genetics or the same life,
So yeah, I think the other thing you wanted, Natalie, was what to take. That was the other issue on when to start.
Yes. So when to start, we covered what to use.
And that gets to be confusing, doesn't it? Because there's so many products out there. So again, this discussion is mostly about hormone products, and
Yes.
that are used to treat perimenopausal and menopausal symptoms.
We could say a few words about the serums at the end, but let's focus on the hormones and the different types of hormones too.
I think that just I think as women we just we have common sense, right? So natural is better.
I think
right?
so. I think so.
Makes sense that, whatever we put into our bodies, let's try to mimic what our ovaries were doing. Let's be natural, right? So, and I think that's kind of the overriding issue that women should be thinking about. And unfortunately, we've kind of had this trial and error with hormone therapy ever since, it's become a, it's just like anything. We're learning, and we're trying to figure out what the best thing is. So we made some mistakes along the line. I mean, a lot of course, is governed by, technology and economics and that sort of thing. But so the ovary puts out, it puts out lots of different hormones, but the main estrogen is estradiol. So estradiol is the hormone that goes and hooks onto your brain receptors and does all its thing. So estradiol is a natural hormone. And then progesterone is the other natural hormone that our ovaries make, progesterone. So we didn't have estradiol that widely available right away, and Premarin, the pharmaceutical company Premarin, they kind of cornered the market for years and years, and that was the drug, and we just
Poor
assumed
horses, poor horses.
Yeah, we won't go into all that, but and I don't want to badmouth Premarin, because there are actually some features about Premarin that actually are quite good. But once we figured out, okay, here's estradiol, let's just use that. That's probably one of the best things to take. And then the second thing that we've learned now is how that estradiol gets into your body. When your ovary secretes it, there's little blood vessels on your ovary, and it just pops out the estrogen into the circulation, and and the estradiol circulates in your body. When you take something with a pill, the pill goes into your stomach and gets immediately into the liver. And the liver is kind of like this, manufacturing complex that does once a drug gets there, it kind of a magic box, and then it changes it a lot. So once a drug goes into your mouth and into your liver, it comes out a little differently. It comes out
less effective.
Well, it's less effective, but it also does some negative things. When you take a pill orally, it actually changes the estrogen in certain ways, and then it also prompts some other changes that are kind of like side effects. So, for instance, taking oral estrogen creates these makes the liver create these proteins that actually make your blood clot more. So when we've heard that estrogen causes blood clots, which it does, I mean, birth control pills and then hormone replacement pills all increase the risk of blood clots, but that's only if they're taken through your mouth. When you put estrogen on your skin, that's like putting it on just the way your ovaries would make it. So
that is huge. Yes, a lot of women in the UK are talking about this in menopause cafes, and it's made a difference.
Oh yeah, I mean, we call that transdermal. Transdermal means on the skin. It comes in patches, creams, sprays, gels, but we think that maybe it's a more natural way to do it. So as far as an estrogen goes, we kind of are thinking that estradiol is the best form, and maybe on the skin is the best way as far as this goes. And there's many different products along those lines.
There are products for vaginal use too. That is very different.
Yeah, and very, very, very low dose.
Very low doses, yes.
Actually, just to treat the vaginal symptoms without getting into your body.
Yeah. How about the bioidentical? It's a little bit confusing.
Yeah, let me just say a comment though about progesterone before we get into that, because
I'm sorry.
So as I said, we're learning. So originally, when we came up with a progesterone type drug, we knew we needed something that was progesterone-like, but you can't take progesterone. We didn't have a progesterone that you could take orally or even on the skin that would get into your system effectively. And so it's taken a long while to come up with an oral progesterone. They literally have to kind of make it into little teeny little pieces with little kind of characteristics to allow it to absorb. So we now do have natural progesterone, but we really didn't have that for a long time. And when natural progesterone finally came out as a pill, it was called Prometrium. I mean, it was like $500 a month or something, it was prohibitive. And now we have a generic natural progesterone. So now we have natural progesterone, natural estrogen, and so those are what people should take. Those are technically would be considered bioidentical. And it gets confusing because people think, well, bioidentical, I didn't think the FDA, there's bioidentical FDA pills, but I mean, or preparations, but there are. But back then, actually, earlier when the WHI came out, a lot of women whose doctors quit prescribing, they turned to compounding pharmacies who were making what they called bioidentical hormones. And literally that's what they were. They were taking estrogen and progesterone and creating their own proprietary products. And then they kind of said, okay, here's your bioidentical hormones. And a lot of, I mean, still as many women take those from compounding pharmacies as they do, from FDA approved pharmacies. And there's kind of some issues going on between like NAMs and their feeling about the bioidenticals, because the compounding pharmacies they're not kind of regulated the same way as other pharmacies. They're regulated by each individual state. And so there's lots of individual variation in the quality control and how they're oversight. They don't go through all the rigorous, steps and testing that FDA drugs do. So there is some concern about when women go to a compounding pharmacy and get a product, they get their estrogen and progesterone. You're not 100% sure if it's got the right dose in it or the right ingredients or if there's impurities. So there is.
They would have to discuss that with the physician who prescribed them anyway.
Right, and
they can.
You got to know. You got to work with your healthcare provider who has a good relationship and trusts the compounding pharmacy that they're using.
Yeah, we just don't go to the pharmacy like we would go to the supermarket to get something compounded or off the counter. So we talk to I don't think we can.
They're pharmacists, they're board certified pharmacists, but
they're serious.
Yeah, but again, some women just order bioidentical hormones on the internet from who knows where. So I think that's the issue.
Oh, it's true. So it's really, really. We would not say do it on your own. Always consult with a very reputable physician. Let's see. Oh, we're going to need to tackle the questions very, very soon. But how long?
Oh, okay. Well, again, the guidelines say the lowest dose for the shortest period of time. I mean, I have to say that's the current guidelines. But if you look at the NAMS position statement, and what many of us believe is that there's no arbitrary cutoff to stopping them. I think a lot of people say, well, so what would you do? And people say, okay, 5 years. I mean, 5 years of treatment, even with a progesterone-like drug, the risks of breast cancer are just vanishingly small. So I mean, if there's hardly any risk to taking them for up to 5 years, assuming you're not they're not some sort of
be revisited, with a physician.
But there's a lot. I mean, a lot of the older studies, and certainly when I first started practice, I mean, I treated women into their 80s and 90s, and I guess it's just how anecdotally and personally you have your own bias. I would watch a 90-year-old come in and hop up on the table, and she was on her hormones. I mean, you could almost. It just seemed like she was so much more youthful. But again, that's my anecdotal personal experience. But there's a lot of studies.
It matters. It matters because you've seen it closely. I mean, for most of us, we've only dealt with our own bodies, not even our relatives, and you've seen hundreds and thousands of women.
Yeah. No, and again, I'm not. Everything I present to you today is based on good science evidence, but again, I just had to throw in my observation. But a lot of these studies have shown that women who take them long term do well. Actually less dementia and increased life expectancy. So again, time will tell about where we're going to come up with the. There's this kind of arbitrary guidelines right now.
And I'm very, very optimistic that you mentioned that there are more and more studies that are being conducted, and that's hopeful.
Yeah.
Dr. Rice, I have the feeling that we need to start taking the questions. But before we take them, and because we, even in an hour and 15 minutes, we could have been talking, for a lot longer. There's so much information in Dr. Rice's book. Just give us, show us your book if you don't mind. And there are so many details. You might want to consult it, read it. But we're also going to, and so this was published in December 2019. So,
Yes.
so it's
Yes.
like a year-ish ago.
The
So it's
estrogen.
very,
Yeah.
yes, Sandra Rice, the Estrogen Question, no before you say no to HRT if you want more information.
Ellen.
So thank you. Did you talk about the terms in your book?
Oh, yes.
Yeah. So yes. So there's, if there is any question on that. Wow, I cannot believe that. We have a few questions. There is one comment, and I have one question here. Well, let's take the time to do that. This person made just a comment when you were talking about your hysterectomies, partial or not partial. She had a very nice comment. She said that she had a hysterectomy at 36, and she had a partial one, but she gone through menopause at 43. So it kind of, balanced it out. She doesn't give any details about how smooth the ride was, but she was trying to say, yes, Dr. Rice, I agree with you.
And let me just, I love questions because they always, spur a little additional.
Of course, that's why we're here.
So obviously taking out both ovaries will put you in immediate menopause. Taking out one ovary for some unclear reason will also make you have an earlier menopause. And taking out your uterus will also have you have an earlier menopause. And you kind of go, gosh, if they leave the ovaries, why would that happen? We're not sure, but it may have something to do with the circulation. Once you do the surgery, you might cut off a little bit of the blood supply. So again, it's probably not uncommon to go through menopause early, if you've had, even just the uterus taken out.
Even just one.
And even just one ovary
One.
and uterus. Yeah. Interesting, huh?
It is fascinating. I mean, there is so much to cover. Let me see. I have 5 other questions there. I think we covered it, and I tried to make it happen. What is the difference between estrogen and estradiol? If estradiol is low, are the symptoms the same as if estrogen is low? So I think you answered, but maybe we need a little tip.
Yeah, I mean, estrogen is a general term like apple. You have your golden delicious and your red delicious and your all these different apples. Estrogen is the term to describe all the different kinds. There's estradiol, there's estrone, there's estriol. But when we actually measure your estrogen level, we're measuring your estradiol, because that's the most potent and major form of estrogen. I mean, you can measure the individual ones, but generally, if a doctor says we measure your estrogen level, we're probably measuring your estradiol level. Does that make sense?
Yeah, absolutely. Well, thank you for answering it. Okay, the next one. I am feeling rather depressed after hearing this. And this was at 1:30. So the woman, I believe, made that. So we were still talking about the risks of menopause and losing estrogen. She said, I'm only 42 and I had an extreme case of endometriosis and adenomyosis and had to have a complete hysterectomy almost 2 years ago. So when she means complete hysterectomy, she also lost her ovaries and her tubes, I believe. That's what it means.
That's a lot of people.
Because it's hard to pronounce. It was just not me. Which sent me straight into menopause. Since then, I developed high blood pressure, and I'm officially pre-diabetic, and I've gained a depressing amount of weight in my stomach. My surgeon told me not to take hormones under any circumstances because of, we can talk about this, even bioidentical hormones, because it would send me right back to surgery again. I'm so sorry. What can I do to protect myself if I can't take hormones? And do you know of any specialists who specialize in how hormones post-menopausal endometriosis patients?
Yeah, I mean, I think that endometriosis issue, we've talked about that, Natalie, is really a tough situation because basically endometriosis is just little cells that originally were on the lining of the uterus. So they're very responsive to estrogen, so with endometriosis, those cells have, have gotten out of the uterus and they go out through the tubes and they can get on the ovaries and then they can move around the rest of the abdomen. And so they're very sensitive to estrogen. So if a woman has endometriosis and you give her estrogen, it can make those cells, expand and cause problems. So, once you've had the surgery, you kind of don't want to go back on the estrogens. But I know there's a lot of controversy about that. Some doctors think if they go on a progesterone-like drug and an estrogen, because sometimes birth control pills actually kind of can calm down endometriosis. So women, if they're taking estrogen and a progesterone, maybe they can get by with taking some estrogen. But it's a real, it's a balance. And
it's really a balance. But you would think that if they remove the organ where those cells are originating, you would think that the mother cells, would not be there to be.
Well, once they drop out, it's hard to get rid of it. It's kind of like a dandelion, that spreads. You can take out the uterus and as much as you can, but there can still be little nests of cells here and there that they can't get it all. So,
it's complicated.
Yeah, if women had very confined endometriosis and they thought they got it all out. But in answer to your question, I think we have talked about, going to the NAMS, North American Menopause Society website. They have a referral list of people who probably.
We had a question like that last time, and I responded to the person by email, sending a couple of resources and also a review of what's has been done. So this person actually sent me the question in an anonymous way. If you wouldn't mind sending me an email, I will respond to you with those resources to be discussed with your physician. And I would definitely go with the North American Menopause Society provider. And I will send you all the websites from the UK. So just email me when you have a chance, and I'll do that for you. We have another few questions. If my only symptoms of menopause are night sweats and weight gain, even though my body fat percentage is super low, would HRT be a good solution for me? I am an athlete and seem to be having a lot of inflammation, all centered in my gut.
Inflammation.
It's a good question.
Yeah. I don't know how old she is, but certainly the hormones do help night sweats, and they, the question is, do they help prevent weight gain per se? They certainly help prevent the abdominal central fat.
Internal, yeah.
But and again, there's a lot of research on how estrogens modulate energy intake. A lot of times, people will do all the same things exercise wise, they'll eat exactly the same thing, and then they go through menopause and they gain weight. And you kind of go, something maybe about the way the estrogen was, affecting the brain telling the body's metabolism how to work. So I mean, there's just so much we don't know, but I think, certainly taking hormones would definitely, I would think, would help the night sweats, because that is a usually related to an estrogen deficiency sort of symptom.
Yeah, and it would be one of those symptoms for which, it would be recommended. Again, email me and we can brainstorm if you like. This question, two more. Okay, so Period stopped 5 years ago. Now have belly fat, vaginal atrophy, skin winkling. Is it too late for estrogen? How
Yeah,
long take it for? I mean, I think we've answered part of it.
yeah, yeah.
And
No,
do I need pap test before starting HRT?
well, the HRT doesn't have anything to do with cervical cancer. So, we do, there's different guidelines in different countries about how often to do pap tests. And so doing a pap test, that'd be something that you would do with based on what your physician recommends. Nowadays, some of the guidelines are saying just to check for the venereal warts, the HPV test, rather than doing annual pap smears. And, if you've had a couple negative in a row. So it depends on just, how your physician feels about routine pap tests, which are for cancer screening of the cervix. But as far as for HRT treatment, I would always, have a patient see her physician and just make sure you're up to date on your mammogram, in your breast exam, and check all your routine blood work and talk to your doctor, make sure there's no other contraindications, like if you've got active blood clots or severe liver disease, etc. But
Quit smoking is also something that could interfere.
yeah, so as long as you're within that window, I mean, certainly the studies show a woman is still a candidate, for hormone replacement therapy.
And I think the attendee from the previous question responded that she's 49. Was it, yes, remember with the person who you wonder how old she was. Would HRT be a good solution for me? I'm 49 and I'm an athlete, yes. Yeah.
Certainly not, certainly within the window for sure.
Yeah. I have one more question, but this one comes from somebody who could not attend. This person has very complicated health issues, and she's seen a lot of doctors. And she says, could you please ask Dr. Rice if she believes my issues are menopause related? So I'm just going to list. She has severe gastrointestinal discomfort, feels like my gut is rotting, horrible breath, burning lip, tongue, throat, and I've tried many elimination diet with little change. She's also looked at other allergies and heavy metals and etc. There's nothing wrong with her except those. She has severe, beside the gastrointestinal problems, she has severe exhaustion, random pain all over her body, difficulty focusing, and at times can't find words. She also has tremors in her hands and head as well. Those are very, very severe symptoms. And when she goes to the doctor, everything is normal.
Yeah, I would probably get a second opinion. I mean, those certainly aren't classic menopausal symptoms. Did you get a sense, is she at the menopausal age? I mean, if you're menopausal age, there's certainly a chance that the menopause is aggravating some of those symptoms, but I would certainly want to rule out everything else. Gut symptoms aren't a huge factor in menopause, although again, everybody's individual, but I would certainly want to look at everything else first.
She did.
Yeah.
Yeah, she did. It's probably got aggravated, but it's just very, very, affecting the quality of life.
I mean, I never want to just quickly say, oh, it's probably menopause without ruling everything else out. But there's a certainly a good chance if she's in the right age group that that's part of her issues, and whether or not hormones would help. Some doctors would say, well, let's just try and see. But again, it's a little bit atypical.
It is a difficult case. I have another question. I am looking into nutritional programs to help with hormone imbalances. I'm currently on estrogen, HRT. Are these programs worthwhile as they are expensive run by a nutritionist who specializes in women's hormone health.
Yeah, I'm not, I'm not sure there's any specific diet that's going to actually affect your hormones per se, so I don't know if that's something I would necessarily recommend to my patients. I mean, I think most of us, again, from an internist standpoint, we would certainly recommend heart healthy diets, like Mediterranean diet and things like that. But I don't know if there's any proof about any specific combination of foods, or nutrients per se that are going to really affect your hormone levels that much. But again, that's just kind of.
I agree with you. I do like to say, I'm looking if it's here, but it's probably in my other room. We talked earlier to help answer that question. I don't know if I will, because I don't really know, the details. But we talked earlier about the link between menopause and Alzheimer's. And so there is this very serious scientist down in New York City who specializes in that, transition. She is a neuroscientist and a nutritionist. Okay, so I've read her books, and I absolutely love her book. It's called Brain Food. It's Lisa Mosconi. And so Lisa Mosconi, neuroscientist, nutritionist, specialized on menopause, Alzheimer transition. You're going to find a lot of very useful tips on what is going to regulate your overall hormones, homeostatic system. Not necessarily, and yes, she's also Italian, so she's really much into the Mediterranean diet, but she does not talk about diet. She brings up, some food that are extremely good for balancing them out. But again, no specific diet, and I think the book is probably $10. So, roughly, it does not cost much money to do that research first. It's 2:32. Wow.
32, but.
Oh, sorry, it's.
Oh my goodness, we've talked a long time.
No, we've actually been on time, because we thought that an hour and a half would be really good. I think that's it. I think we have the questions. We talked about, the hormones. We talked about the difficulty around endometriosis. We talked about the symptoms. We talked about the benefits of HRT. We talked about the guidelines and WHI, and how, it was not optimal at that time, but we're still following those guidelines. Oh, I have another question. Popped up. Okay, well, thank you, thank you. I am, oh, no, I think I got it. Somebody said, thank you, Dr. Rice and Dr. Bonafé. It's been really enlightening. Well, I'm so glad. So again, you can, I'm not a physician. I always recommend you work with physicians on very specific, but I'm great at brainstorming with you and seeing what resources you need. So you can always contact me through that email, or Bonafé at nataliebonafé.com. So that's one way. And Dr. Rice, again, I mean, your book is called The Estrogen Question, and it was published at the end of 2019. It's very fresh. It's analyzed all the research around the hormonal menopausal management options. Just, it's again, it's probably $10 or $12 It's a very good, and if you have any questions, after you sleep on this, don't hesitate to contact me.
And I also, my website is yourestrogenquestions.com. And I'm trying to, as time goes on, update information in the book. So
And you do write some blogs as well.
Yes, at yourestrogenquestions.com, and also on LinkedIn. I've been trying to write some articles that kind of bring out some of the controversies about hormone therapy.
Yeah, well, thank you so much. It's a delight working with you.
And fun.
It's fun. It's fun. And what's really important, what we care about is that more and more women know about the options, about the risks, about the benefits. We have a few tips, the North American Menopausal Society, because we're based in the US. And so I guess for the ladies in the UK, we can discuss. I'm sure you have good resources as well.
The British Menopause Society, I think it's a very active group. And the British Menopause Concerns or something like that. They're, I've actually been impressed with the organization as well.
They are really on top of it. You could also decide if you'd like to join the Menopause Cafe Connecticut. This is if you are in the US. This is at 6 p.m. Eastern Time every 15th of each month. There are other options in other countries, but this is pretty much the only one in the US. And we can just continue to support and promote education and empowerment together. Thank you, Dr. Rice.
Thanks, Natalie. Enjoy the day.
Bye-bye.
Thank you all.
Bye. Thank you.